Hi there! I assumed that you are here because you had already done watching the first two parts of this video tutorials and lecture. Now that you are equipped with the basics of ECG, it will be easy for you to understand how to interpret and read EKG. This is the 10 steps in reading ECG. Okay, let's discuss these steps in details. Step number 1 is to determine the rhythm. When determining a heart rhythm, you should look for P waves, which is a sign of atrial excitation. When every P waves is followed by a QRS complex, the ECG shows sinus rhythm and determine if the rhythm is regular, regularly irregular, or irregularly irregular. Assess the RR interval if consistent with the following beats. You can use a caliper or simply use paper and mark the RR interval and compared with the preceding RR interval. Here is an example of perfect normal sinus rhythm. This is lead 2 of the ECG. To assess the cardiac rhythm accurately, a prolonged recording from one lead is used to provide a rhythm strip. Lead 2 usually gives us a good view of the P wave, and lead 2 is commonly used to record the rhythm strip. As you can see, the RR intervals are consistent, P wave is present, and followed by QRS complex. Therefore, this ECG is regular sinus rhythm. Here is an example of regularly irregular rhythm. Let's examine the lead 2. The RR interval varies but does so in repeating pattern and it has regular drop beat. Not only lead 2 but it can be seen in all leads, right? This is the typical second degree AV block type 2 ECG or right bundle branch block or Morbitz type 2. And here is the irregularly irregular ECG sample. Let's check the longer strip lead 2. There is no pattern. QRS complex seems to come random in unpredictable pattern and it has no identifiable P wave, which occurs commonly in atrial fibrillation. Alright, the next step is to determine the rate. So, if the rhythm is regular, count the number of large boxes between two R waves. Example, in this regular sinus rhythm, there are 4 large boxes within the RR interval or between the two R waves. Then use that number of boxes to divide 300. So 300 divided by 4 is equal to 75. Therefore, the heart rate is 75 beats per minute. If the rhythm is irregular, count the number of R waves in a complete 6 seconds ECG strip and multiply it by 10. So here is the example. In this 6 seconds ECG strip, the rhythm is irregular. There are 9 R waves or QRS complexes on the ECG. Therefore, 9 times 10 is equal to 90. So the heart rate is 90 beats per minute. The 300 divided by number of the large boxes between two R waves is only applicable for regular rhythm ECG. That's the reason you should determine the rhythm before the rate in order for you to use this easy method of calculating heart rate on ECG. Okay, step number 3 is to identify the axis. If you haven't seen the previous video on how to determine the cardiac axis, please watch the part 2 of this tutorial. Okay, we have 4 cardiac axes. Normal cardiac axis, the left axis deviation, right axis deviation, and the northwest axis or indeterminate axis. Some other books or references call this far right axis deviation or far left axis deviation or extreme axis deviation. Alright, in order for you to determine the axis of an ECG, you should memorize the Cabrera system of cardiac axis. Or at least you have this with you if you are reading an ECG. So this is the Cabrera system. If you remember in part 2 of this tutorial, I have mentioned that the fastest non-specific method to determine the QRS axis is to find the major direction of the QRS complex if it is positive, meaning upright deflection, or negative downward deflection in leads 1 and AVF. Okay, step number 4, assess the P wave. The P wave morphology can reveal right or left atrial hypertrophy or atrial arrhythmias and is best determined in leads 2 and V1 during sinus rhythm. Here are the characteristics of a normal P wave. The maximal height of the P wave is 2.5 mm in leads 2 and 3, and that is equivalent to 2.5 small boxes vertically. The P wave is positive in lead 2 and AVF and biphasic in V1, meaning either negative or positive. The P wave duration is shorter than 0.12 seconds or 0.08 to 0.10 seconds. If the P wave is inverted, it is most likely an ectopic atrial rhythm, meaning not originating from the sinus node. This can be seen in a junctional rhythm. As you can see in this example ECG, the P wave is inverted in lead 2 and AVF. This scenario occurs when the sinoatrial node is not able to generate an action potential or fires electrical signal, and the atrioventricular node or the AV node acts as the main pacemaker of the heart. In this instance, the P wave morphology will be altered since its origin is no longer at the SA node and instead at the AV node. This ECG is a junctional rhythm. In junctional rhythm, the direction of conduction to the atria is considered retrograde since it is traveling up to the atria from the AV node instead of down the atria from the SA node. This results in an inverted P wave in lead 2, which is normally upright in sinus rhythm, and an upright P wave in AVR, normally inverted in sinus rhythm. Okay, how about peak P wave? A peak P wave, which is greater than 0.25 millivolt, suggests right atrial enlargement, or cor pulmonale, or sometimes we call it P pulmonale rhythm. This is an example of right atrial enlargement that can be seen in a patient having right-sided heart failure or cor pulmonale. The P wave in this ECG is prominently peaked, so we call this ECG a P pulmonale rhythm. Okay, how about the amplitude? A P wave with increased amplitude can indicate hypokalemia, and a P wave with decreased amplitude can indicate hyperkalemia. Here is another pathological P wave. As you can see, it seems to have a coupled P wave or bifid P waves. This is known as P mitrale. It indicates left atrial abnormality, may be caused by atrial dilatation or hypertrophy. If at least 3 different shaped P waves can be seen in a given ECG lead tracing, this implies that even if one of them arises from the SA node, at least 2 others are arising elsewhere. This can be taken as evidence of multiple ectopic foci and is called multifocal or multiform atrial rhythm if the rate is less than 100 beats per minute. This is an example of multifocal atrial rhythm. Take a look at the lead 2. It seems to have multiform P wave and the rate is less than 100 beats per minute. And if the rate is over 100, it is multifocal atrial tachycardia and it appears like this. This rhythm is particularly common in exacerbations of chronic obstructive lung disease. If the baseline has a total irregular form, This suggests fibrillatory waves of atrial fibrillation, or possibly artifacts if the rhythm is regular. And then, a sawtooth-shaped baseline suggests the flutter waves of atrial flutter. With either of these rhythms, if the ventricular rate is fast, the fibrillatory or flutter waves can easily be misinterpreted as P wave. How about if the P wave is not present? So, absence of the P wave with a flat baseline may indicate fine atrial fibrillation. So, this is a fine atrial fibrillation with a secondary escape rhythm or sinoatrial arrest. Next step is to check the PR interval. Normally, PR interval ranges from 0.12 to 0.20 seconds in duration, that is equivalent to 3 to 5 small boxes. Variations in the PR interval can be associated with certain medical conditions. A long PR interval over 0.20 seconds indicates a slowing of conduction between the atria and ventricles. Usually, this is due to slow conduction through the atrioventricular node. This is known as first-degree heart block. So, examine this ECG sample. As you can see, PR interval is evidently long. Whereas, a short PR interval or less than 120 or 0.12 seconds may be associated with a pre-excitation syndrome such as Wolff-Parkinson-White syndrome or junctional arrhythmia. This is an example of Wolff-Parkinson-White syndrome. A variable PR interval may indicate other type of heart block. And if PR segment depression is present, it may be indication of atrial injury or pericarditis. Alright, step number 6.